So this is the poster I'm maybe the proudest of, because this is, my idea. When me and Dr. Kaur is my co-author on this, and we thought about this a lot. And this is a project, a real-world analysis through the US Myeloma Immunotherapy Consortium. The idea is that if you look at all the studies of any bispecific in myeloma, like Majestic 1, Monumental 1, Magnetism, even Linker MM1, the median time to first response is almost always between 1 to 1.5 months. Why? Because after step-up dosing on cycle 2, day 1, which is typically 28 days later, so about 1.5 months after starting the step-up dosing, you check a response. And for patients who respond, they respond typically. And for those who don't, anecdotally, many of them never respond, right? And so you can see, for example, with any bispecific, there's a large dichotomy between the PFS and duration of response, because really those T cells and that disease are very different populations. That emerges very quickly that those who have a response often have a durable response, those who do not, do not. And so I've struggled with this. Truly, this came out of my own clinical experiences where patients are disappointed, right? And I get it, right? Because they went through all this time, the risk of CRS and ICANS, and we talked about infections, and we were largely doing them in the hospital. So they were in the hospital for 7 days, and cycle 2, day 1 emerges. They check their response, and the light chains are maybe down a little bit, but not all the way down. And it's frustrating. And the question then becomes, well, do I stay on this horse? Do I jump to a different horse, right? Do I move to a clinical trial? Do I move to a CAR T or something along those lines? And so we specifically sought to ask, with a large real-world data analysis from 14 centers, hundreds, I think it was almost 400 patients altogether, 140 of whom were day 30 non-responders. So the largest collection we've ever seen of patients who had not achieved the response by day 30, again, cycle 2, day 1. What happened to those patients, and can we predict who are the ones where if you just stay calm and carry on, so to speak, with dosing, you're able to get them to a response, versus those where this is a little bit of a lost cause and time to switch directions? We looked at a bunch of covariates. In brief, what seemed to matter was ALC, absolute lymphocyte count at day 30, and the presence of early CRS. Early CRS we defined as within 3 days of the first dose, regardless of the step-up dosing schedule. Interestingly, not baseline ALC. Everyone you start to see after Teclistamab, or after, this goes with Teclistamab, any bispecific, you see a small dip because the lymphocytes that are being engaged get to work and they're no longer in the blood. So you see a little dip in ALC. At day 30, those who had a persistent or had a preservation of their ALC, the ALC had returned to normal, were much more likely to respond with continued dosing. Similarly, those who had early CRS early on, even didn't respond, something was clearly happening, and those patients, specifically with early, not delayed, not never, tended to respond. And so if we end up treating them as kind of risk factors, so to speak, just a quick calculator that we talked about in our poster, if you look at one predictive factor as a day 30 ALC over 0.5, 1,000 cells per microliter, and if you look at CRS onset with less than 3 days as independent predictor, again, these were independent in our analyses, for those who had both, about half of them, 48% of them, went on to get a response by day 90. If you had one and not the other, it was about a quarter, 23%. And if you had neither, so if your ALC was still low at day 30 and you hadn't had early CRS, only 7% of them went on to have a response. And again, this model included, for example, like extramedullary disease, it included disease burden, it included prior BCMA, it included, higher cytogenetics. And so none of those mattered. And again, we included ALC at day 0 and at day 7 also didn't matter. So what I would say is to your patient, if you're listening to this, so hopefully we'll get this published soon. If cycle 2, day 1 emerges and the light chains have not reduced 50% and you're disappointed and your patient's disappointed, I would say, take a look at our calculator. Again, if the ALC is high, like normal or high, and if they did have early CRS, I would say 50-50 chance they will eventually have a response. So I think it's reasonable to carry on. Versus if they didn't, you can try. However, I would say it might be time to move to a different bispecific or to CAR T or a different type of clinical trial construct.